Hey, BC here for BC Nephro. Thanks for watching. Today, moving on in our Dialysis Rounding Primer, going to talk about the management of anemia in dialysis patients. For other articles on the Dialysis Rounding Primer series, check out this link in the description at bcnephro.com or check out the playlist at this channel, this YouTube channel at BC Nephro. So, important parts of anemia management. Anemia is almost a universal finding in patients with dialysis. So important things about the management include erythropoietin. These patients with kidney disease are often EPO deficient because the kidneys make EPO. Iron, which is an important part. We'll talk about iron deficiency and relative iron deficiency. We'll talk about a little bit about transfusions, my approach to transfusing patients, dialysis patients, and also, what's the deal when the hemoglobin is actually high and the patients don't need EPO? What do you think about there? So the first thing, an erythropoietic stimulating agent is mainstay of treatment in dialysis patients. First generations are Epogen, Epotin alpha. Aranesp is a second generation agent often given in chronic kidney disease or in oncology, hematology oncology. The one that's more often used in dialysis is something called Mircera, which is a continuous erythropoietin receptor activator. These are driven by protocols, and so there's not going to be a lot of management when you're following the dialysis patients. The most of it's going to be driven by a dialysis provider protocol, which has an anemia manager. Some things to think about are what to do when the patient's resistant to EPO. Some patients need to be managed off protocol that is not appropriate for them. Some patients may need to have higher doses to maintain than the protocol allows. Some patients may have a lower hemoglobin target, so it's important to keep these patients off protocol. Maybe patients with cancer or some other issue would have a lower target. These targets for hemoglobin in dialysis patients are pretty narrow, in between 10 and 11.5. It's tough to keep it the hemoglobin between target, and if the erythropoietin stimulating agent is abruptly held, the hemoglobin can rapidly drop, and then if it's started, it can rapidly increase. So the idea is having gradual dose adjustments to try to prevent these wide fluctuations in hemoglobin, which may not be good for the patient. So there's a number of causes of erythropoietin resistance. One of the main causes is iron deficiency, so we'll talk about iron. Other causes are infection, malignancy, other hemoglobinopathies or things like this. These are things to consider in the evaluation of people who are erythropoietin resistant. Next, moving on to iron. Iron is an important part of the management of dialysis patients, and is often given, almost universally given intravenously for a number of reasons. One is that oral iron is not absorbed very well in dialysis patients because of the chronic inflammatory state. Now, patients on hemodialysis particularly lose a lot of iron each year. They have blood loss through the hemodialysis circuit, blood loss through lab draws, procedures, things like this. Typically lose 1 to 2 grams of iron a year. So a maintenance dose of iron is often given either weekly or every other week. The other thing to know about anemia management in dialysis patients regarding iron is that the typical diagnosis of iron deficiency based on ferritin and iron saturation are not very applicable for a couple reasons. One reason is ferritin is an acute phase reactant, and dialysis is an inflammatory state, so the ferritins are going to run higher even if the patient is truly iron deficient. And the other thing is the bioavailability of iron because of the inflammatory state is not as high. So typically, maintenance doses of intravenous iron will be given unless the ferritin level is greater than 800, or some cases greater than 1200. Bolus loads of intravenous iron are given for a ferritin of less than 100, or if it's less than 200 and the patient's anemia and also has a low iron saturation. Iron should not be given in patients with active infection. That's a thing to think about there. The third thing to talk about is blood transfusions. So blood transfusions should be avoided in dialysis patients. Prior to the days of EPO, this was an important cause of secondary iron overload, and so that's one issue. The second issue is that there can be alloimmunization from the red blood cell transfusions, which may increase the chance of a positive cross-match for a potential kidney transplant. So for these two reasons, in addition to the other infectious and transfusion associated reactions and things like this, in the general population, transfusions are avoided. Personally, I think the hemoglobin cutoff of 7 for dialysis patients should be liberalized a little bit to about 7.5 for a couple reasons. One is if the hemoglobin is slightly above 7 and the transfusion is held, and then the next day, maybe in a hospitalized patient, is less than 7 and the patient needs a transfusion, you may have problems with access. Dialysis patients often have poor IV access, a problem managing the volume, and then you're have the patient requiring an additional dialysis session that maybe you could have avoided for giving the transfusion when the hemoglobin was in between 7 and 7.5. The second thing I frequently see is outpatient dialysis patients have a hemoglobin less than 7, and then that patient is sent to the ER for evaluation. Now the patient is sent to the ER typically after dialysis. So after the dialysis, there was some ultrafiltration, they're somewhat hemoconcentrated, so now the hemoglobin that was slightly below 7 is slightly above 7. So the ER says the hemoglobin's above 7, send them home. Prior to the next dialysis session, now the hemoglobin's below 7 again, and you go through the whole cycle. So in between 7 and 7.5, I would consider a transfusion in a dialysis patient. The last thing I'm going to talk about here is some dialysis patients whose hemoglobins are normal or high and they don't require erythropoietin. So what's the deal here? Of course, these patients, like any other patients, can get polycythemia vera, and you can check a JAK2 mutation or things like this. But a special thing to think about in dialysis patients is there another reason that the kidneys are making EPO even though they failed. And the thing to think about is potentially renal cell carcinomas can secrete EPO. So typically in these patients, there's a screening ultrasound just to make sure you're not missing a renal cell carcinoma. Now this is something that is often talked about and done. I haven't picked up a renal cell carcinoma or seen one picked up this way, but this is something to be aware of. Also, polycystic kidney disease patients, the polycystic kidneys may secrete EPO as well, so that's another cause. So that's it. This is the anemia management. Any questions or comments, please email me at brian@bcnephro.com. Leave the comments in the comment section below, and until next time, have a good one.